Hello, dear colleagues. Thank you for joining us. I am grateful for the invitation to give me the opportunity to be part of this scientific meeting. I am glad to meet you, and it is my pleasure and honor to be part of this conference. I will talk about the dyslipidemia challenges and the gap between the guideline and implementation of the guideline. Who will win the champion is the word say between the challenge between the guideline and implementation of it is in daily practice. The educational impact of this talk, I will start with key facts and end with home message. Fact number one, the prevalence of dyslipidemia is still debatable. As you know, the global prevalence of dyslipidemia around 39, variable between male and female, range from 37 in male to 40 in women, and the prevalence twice higher in those with high-income countries comparing with low and middle-income countries. What about dyslipidemia in Iraq? 2 out of 10 responded to measuring blood glucose in Iraq, and 1 out of 10 were notified to having hypercholesteremia. This is recorded in the STEP survey did by Iraqi Hypertension Ministry of the Health in Iraq 2016. And this is a study published in 2007 in Mosul. The prevalence of dyslipidemia in Iraq is high. And another study did in a Najaf center found that the variation in lipid profile associated with gender and age, and a large number of patients accidentally discovered have had dyslipidemia. The rank published in 2020, World Rank of Coronary Heart Disease 23 in Iraq. And let me go to the fact number two. The target of low density lipid reduction is still not reached, and the goal of low density lipid across the categories of cardiovascular risk should be below 116 milligram per deciliter in those with low cardiovascular risk, and below 100 in those with moderate cardiovascular risk, and below 70 in those with high cardiovascular risk, and those with very high, the range should be below 55 milligram per deciliter. And totally should be the reduction of low density lipid cholesterol in those with high risk cardiovascular patient should be more than 50% from the baseline. Definitely in 2019, the ESA guidelines say that the goal must be below 40, and that reasonable to be class 2B, level B, according to those patients with established ASCAD with recurrent event, should be the low density lipid cholesterol below 40. And globally, and in Danish study, they found only 18% reach the target of those with established ASCAD, reach the target of low density lipid cholesterol. And among all patients, only 33 reach the target. And in the Eurospire 5 study, found overall from this biggest study, around 7,000 patients, they found overall 71 not get the goal. And when compare the Eurospire 4 with Eurospire 5, nearly double dose of intensive statin monotherapy, but still, in spite of larger intensive therapy of statin, they found 7 out of 10 do not reach the goal of low density lipid. So, in conclusion, the more your low density lipid, more benefit. Lower is better, and average is not good. and high is bad. And this is studied in Tikrit in Iraq. They found that only 1 of 4 from those who received treatment reaching the target of low density level. Fact number 3, should start early. A long duration of low density lipid therapy is essential. And according to this slide, this busy slide found that central role of low density lipid and the ASCA depend on low density and apolipoprotein. And they found that the early start of low density lipid therapy might be reduce the cardiovascular event. So early exposure of the reduction of low density lipid will reduce threefold of the cardiovascular risk compared with those who started late. Again, in 2022 in Barcelona, they said that absolute reduction of low density lipid and duration of this reduction is the key to reduce the cardiovascular risk. Fact number 4, aggressive and combination therapy is better. And according to a lot of study, they found that 1 millimole reduction in low density lipid cholesterol associated with 22 reduction in the relative risk of major vascular event. And from this point, we found that use of combination as a first-line therapy in those with very high and high risk cardiovascular patient started with statin and zitimab, or statin with zitimab plus monoclonal antibody to get the target. So single pill combination is better to start it early and better for adherence. And there is a change in paradigm from statin monotherapy toward the intensive lipid lowering regimen. And this combination lipid lowering therapy as a first line strategy in very high risk patient is published in 2022 in ESC guideline and ESC articles. And they found that in conclusion, should start early, treat much aggressively, and use combination to get lower and earlier long duration. Long is better than late. Fact number 5, investigation dyslipidemia is still not clear, and measuring of atherogenic lipid is still debatable. Measuring of atherogenic lipid depend on Fried-Ward equation, old equation. It is underestimated. The best way to calculate it, non-high density lipid, which is a very simple calculation, clinically very useful. Fasting lipid profile, not mandatory to get the measuring of lipid profile. Apoprotein add information to estimate the cardiovascular risk factor. And in case of statin resistant, the biomarker to estimate residual risk is lipoprotein A can be used. Fact number 6, overpromotion of adverse reaction of lipid lowering therapy. As you know, there is a lot of side effect and adverse reaction like muscle pain and headache, fatigability, etc. And there should be a balance between the side effect and the benefit of lipid lowering therapy in management of cardiovascular risk. And despite the demonstrated benefit of a statin, a large number of patients still remain at worry because of adverse side effect. Fact number 7, physician inertia of use of lipid lowering therapy. As you know, the clinical approach management should assess the cardiovascular risk with a scoring system, then determine the goal of therapy and make recommendation according to the stage of cardiovascular risk factor. And use of a statin or underuse of a statin, one of the main issue in the management of acute cardiovascular and management of dyslipidemic patient. And only 40% of patients with acute coronary syndrome are adherent to the statin treatment. And when found this busy slide, they found that low density lipid cholesterol and should have started earlier and those with high risk and very high risk and intensively and added zitimab or monoclonal antibody to reach the target in management of dyslipidemia. And as you know, the, there is a study found the comparison between therapeutic inertia and the physician years of experience concluded that therapeutic inertia was the common in patients with chronic ischemic heart disease and dyslipidemia, irrespectively of overall cardiovascular risk factor. Fact number 8, price of the low density lipid therapy and generic versus brand. As you know, that there is a large number of generic versus brand therapy in the market, and there is a difference in the price. And this is a comparative effectiveness study of generic versus brand in 2014 cohort study involved 90,000 patients, concluded that the patient initiated generic statin were more likely to adherent and had lower rate of composite clinical outcome. Fact number 9, gaps in implementation of the guideline. Uh, the gaps can concluded lack of familiarity with guideline, patient reluctant to be treated with high intensity therapies, and high cost of some medication, and there is a concern about statin adverse reaction. So the main barrier is non-adherence to the statin therapy, and a cause of non-adherence might be related to the patient, physician, or healthcare system, and concluded by the cost of medication, aggressive adverse reaction, knowledge about medication, and belief of self-medication, and confidence with the physician, and that's related to the physician, knowledge and inertia, time spent with patient, and the healthcare system related factor might be related to the accessibility and availability of therapy and acute care rather than systemic focus on the prevention. How to overcome those barriers? Evaluate cardiovascular risk and educate the patient about the risk. Educate the patient about statin benefit and strategy of adverse reaction, use of most effective therapies approach. And there is a recommendation for implementation of the guideline and class 1 recommended by the ASC 2019 simplified the dose regimen and consider fixed dose combination pill were available and can use a lot of method for reminders including calendar and telephone, otherwise depend on the smartwatch. uh, and as you know the drug availability for patient is still one of the main obstacle, and there's a lot of part for discussion, including increased availability of drugs, should a new drugs incorporated in the management, and how can new drugs be used to enhance medical adherence. In conclusion, the guideline and its implementation is a very important categorize of cardiovascular risk, and the goal of low density lipid is crucial. All recent guidelines supported aggressive early long duration and keep low density lipid lower. Focus on overcome barriers, educate and orient about the inertia of the physician and patient. Side effect, avoid media reputation effect worse than good. And please not to stop or change your therapy without advice. Thank you very much.